Today we'll be starting our next session on symptomatology and cardinal manifestations. The next thing that we are going to talk about is fatigue. So this may appear to be a very dull topic, but actually what happens is it's one of the most difficult symptoms to dissect. And more often than not, this is the symptom that actually comes to your OPD, and you'll have a hard time in actually finding out where is the fatigue coming from. So at that point of time, we have to understand that fatigue is a topic that comes only purely to the OPD and not to the emergencies. So because of that reason, we must be well aware of how to dissect fatigue and that some syndromes associated with fatigue. First thing, what is actually fatigue? We're going to be looking at what is fatigue, first of all, and how to dissect fatigue from symptoms that appear like fatigue. Because what happens is the symptom like fatigue actually, the patients actually tell that it is fatigue, but sometimes it is not at all fatigue. It might be weakness, it might be fatigability, it might be as simple as, patient not having a good night's sleep the night before. So we're going to actually find out and re-emphasize history taking in fatigue and how to approach a patient with having a predominant symptom of fatigue. So when I'm saying that this session is approach to fatigue, let me make it clear that the approach to fatigue means approach to fatigue as the primary symptom or a part of it where fatigue is actually prominent. Okay, we cannot approach fatigue where fatigue is one of the symptoms present, where the major symptom could be something like heart failure or cough with hemoptysis or frank anemia or like that. So mostly the cause of fatigue are all secondary. That means that we need to be sure that we have ruled out common causes like anemia, hypothyroidism, adrenal insufficiency, pregnancy, etc. before approaching a case of primary fatigue. So once we have actually crossed that phase wherein we have seen all the common causes, we come to the more difficult one, that is a primary fatigue syndrome. Primary fatigue syndrome, I will go in detail because that is not mentioned and not given importance to in an OPD sitting. I have classified myself, so I don't want to draw flag, that fatigue can be approached in two different ways. One, where fatigue is a forthcoming symptom, where fatigue is actually the primary symptom. Okay, so these are all cause of primary fatigue syndromes. And then you have fatigue as a part of another few syndromes, which are called as COPC. So COPCs are basically a group of disorders which are all having a common theme of multifactorialism. So they're called as chronic overlapping pain conditions. So chronic overlapping pain conditions is all dealt in the last 5 to 6 sessions that we have had. I have dealt with one or the other chronic overlapping condition. Today we'll be able to summarize it and view it as a single entity. So basically they're overlapping condition. That means one patient having one syndrome will have the other syndrome also. Okay, so that is the way to approach fatigue according to me. This is primary fatigue. Secondary fatigue I will not be talking in detail because it is like basically talking about hypothyroidism in detail or anemia in detail, which has to be talked when we go into systemic disorders. So what is fatigue? Okay, so fatigue is basically a subjective. This is the Harrison definition. Again, I'm putting mainly from 21st edition of Harrison's, where it's a subjective experience of physical and mental weariness, sluggishness. And the patient actually, clinically to us, the patient is not having the ability to initiate movement. He's not having the will, or he's not having the energy internally, and because of which externally no locomotion or no activity is taking place. So it is almost like it is the disorder of the mind, where the patient is not having enough energy internally to manifest outside. Okay, this has to be differentiated from disorders which have mental willpower, but actually is physically incapable of actually carrying out the activity, which is basically weakness. So in context of clinical medicine, fatigue is difficulty initiating or maintaining voluntary mental or physical activity. Okay, so that's the definition of fatigue. This is the Harrison's definition of fatigue, which can be asked and is important for us to know. So fatigue can be either chronic, which is more than 6 months, or it can be acute, which is less than 1 month. Anything in between is a gray zone, is subacute. So less than 1 month is acute fatigue, and more than 6 months is chronic fatigue. But this definition or this timeline is totally hazy when it comes to individual organ systems. If fatigue is associated with hypothyroidism, we can't use this. This is used only if the fatigue is primary and not secondary. Okay. So let us say you got a patient in the OPD who is a 40-year-old man, and he is telling he has fatigue. Okay, he tells you in his own vernacular language that he has fatigue. So it could be thakan, it could be something that he is unable to do functionally. Okay, that can be told by him as fatigue. So he will say something like tiredness, or he might tell weakness, or he'll say inability to do. Okay, inability to do is the most important thing that he does. This can mean 1,000 different things. And how do we go about it? If you ask him an open-ended question, which is always what you have to do, you have to ask him an open question. An open question is basically explain to me in more detail. What does this mean? What does this tiredness mean? So when you actually ask him in such detail, you will get a story that is extremely in detail, and he might go tangentially in various directions. So at one point of time, you have to stop him short and ask some closed-end questions. So in fatigue, because it's a very difficult symptom to actually take history, a lot of closed-end questions actually come up. We have to first elicit two things. One is organ system wise. You need to go on asking organ system wise if there are any problems in each organ system. Okay, that is the first thing that you have to do. The second thing that you have to do is basically find out if it is true fatigue. Okay, true and pure fatigue, which is not basically anything but fatigue only. So this is pretty direct, where you ask patient like, has he lost any blood? Is there GI bleeding? If it's a female, is there any possibility of pregnancy? Has she had her menstrual cycles regularly? Is she having dry skin? Is she having loss of hair? Any recent weight gain or weight loss? So you ask basically symptoms of anemia, heart disease, respiratory disease, thyroid, adrenal insufficiency, recent surgery, GI, family history of cancers, etc. So all these symptoms need to be asked, because most importantly, secondary causes. Once you are doing this, at the same time, you have to start asking about true fatigue. Now, dissecting this symptom is actually very, very important, because you can't dissect it easily. So let us say I have made up a small algorithm of how to dissect whether it is actually fatigue or it is something like fatigue or fatigue mimics. So let us say, I'll explain to you in an example. Let us say you have a man that is walking 6 kilometers. Okay. He comes to you with a complaint saying, why, after I have walked up to 6 kilometers, which I used to do previously without any problems, now after walking 6 kilometers, I'm stopping. I am stopping because of, let us say he has leg cramps. So once he has leg cramps, you will ask if it's unilateral or bilateral. So this could be possibly intermittent claudication. This is vascular claudication. Okay, after a lot of activity, he's going to get that pain because of increased lactate production, because of decreased blood supply. That is intermittent or vascular claudication. It could be peripheral vascular disease. Let us say he comes and tells you, why is he stopping? You have to ask him why he's not able to do the activity, or why he's stopping after 6 kilometers. If he says he's stopping because of air hunger, they usually tell, I'm not able to catch my breath. Or he says, I'll have to start panting. I start panting. I start taking in more air and air. That is basically dyspnea, a type of dyspnea. This is basically probably due to a respiratory cause or a cardiac cause. If it's a respiratory cause, the patient will have cough, he'll have symptoms of TB, he could have wheeze, etc. If it's a CVS cause, he could probably have ascites, pedal edema, heart disease history, etc. So this is the reason why he stops. The third reason why someone could stop. Actually, what happens is, let us say he starts walking from 1 kilometer to 6 kilometer. And he says, let us say he repeatedly starts using only his legs. He's on the elliptical, he's on a stairmaster or anything. He walks repeatedly using the same group of muscles. And he stops because that particular group of muscles is giving away. So giving away basically means that the muscle group is actually fatigued because of repeated activity. So this repeated activity leading to a particular muscle group going completely weak, and he gives away. He's unable to do the activity, but there is no pain as such. Okay, this is basically called as fatigability, where repeated activity leads to fatigue or weakness in certain group of muscles. And this is very classical of myasthenia or any NMJ disorders, neuromuscular junction disorders, presents with easy fatigability. So in history, if you're using fatigability, that means that you are going to indicate to the examiner that you're talking about a neuromuscular junction disorder. So please don't, if you're wanting to talk about a patient who's having a cardiorespiratory disease or anemia, please don't use the word fatigability. More often than not, we see a lot of people who are start the chief complaint as easy fatigability in 6 months. So you can't use that, because fatigability means that it is an NMJ disorder. So this is the third thing that they can tell. The fourth thing that they can actually come up with is, they need not walk up till 6 kilometers. They're severe. So they're unable to start or initiate the activity by taking 1 or 2 steps itself. So during the first 2 steps only, first 2-3 steps only, if they're having a lot of pain in the leg or in the hip, that represents neurological claudication. So neurological claudication could be a spinal disorder. It could be a nerve root compression in the lower limb, etc. So these are neurological claudication compared to the first one, which was vascular claudication, which would have let the patient actually walk to a certain distance. The last one is when the patient is unable to start the activity only. He's unable to start the activity. That means, let us say the activity was to go and get a cup of coffee from the kitchen. He's unable to get up from the bed itself. Correct? So if he is giving a complaint like that, wherein suddenly he is unable to get up from the bed only, then forget about all these symptoms of leg cramps and dyspnea, which won't even happen. He's unable to initiate the activity. But is there pain? There is no pain. Does he want to do the activity? Yes, there is will to do the activity. Will is present. He has the energy and the motivation to do it. He wants to do it. So if there is no pain, there is will to do the activity, but he can't initiate the activity. This is neurological weakness. This is neurological weakness or paralysis or paresis. Actually, this is paralysis itself, because he's not able to initiate the activity only. Something above over here could be paresis. Now, if there was pain in this condition, okay, generally pain is present, will is present, but still is not able to initiate the activity. We call this as pain restricted activity. Pain restricted activity, that could be an orthopedic weakness. Basically a bony, muscular or musculoskeletal weakness. Okay, that is one thing that you can say when the pain is present. This is a generalization. There could be a rare exceptions, but this is usually how the patient actually complains. This is what he indicates. But he will all represent all these symptoms as fatigue or tiredness or weakness. So we have to ask these closed-end questions to find out why he is stopping the activity. Does he have the willpower? Does he have pain during initiation? Is he able to maintain the activity? Is he able to complete the activity without leg cramps or dyspnea? All these questions need to be asked to find out whether these symptoms are present or not. At the last, the topic of discussion today is fatigue. So where does fatigue fit in? Fatigue is when the patient actually doesn't have pain, the patient doesn't have will, patient doesn't have energy. Hence, a generalized depletion of energy with no pain, and hence he is not unable to initiate activity. Or if he initiates, he doesn't have the enthusiasm to continue the activity. That is called as true fatigue. That is called as true fatigue. So this is basically the algorithm to identify patients when they come with something called fatigue or tiredness, which is a general word that they use. At this point of time, you will ask them what makes them get fatigue, or what relieves the fatigue. So you have to ask question: can you initiate the activity? Do you have willpower to do the activity? Is there any pain during the activity or while initiating the activity? If all of these are giving you answers, then you will be able to classify them, whether it is fatigue, is it orthopedic weakness, is it neurological weakness, is it fatigability, it is a cardiorespiratory disorder or anemic disorders, or it is vascular or intermittent claudications. So these are the symptom complex of fatigue. Okay, but true fatigue is the last one, when the patient doesn't have, his patient basically, let's say he is depressed. So it is associated with a disorder of the mind also, where the patient is having willpower that is lost, hence he is unable to initiate or sustain any activity, and that is called as fatigue. So any history sheet in fatigue, you will ask them what is the duration, 1 month to 6 months. It has to affect activities of daily living. You will not get a patient whose fatigue is not affecting the daily living and he's coming to you to for help. It has to affect daily living, and you want to classify how badly it's affecting his functional status, whether it is increasing, stable, or decreasing, and what relieves the fatigue, sitting down, posture, all that has to be asked. You have to ask again, targeted history of the organ system, always without fail. Any recent illness and a prolonged recovery. So basically what happens is, a lot of these viral illnesses basically, usually most of us have a viral illness and we are completely relieved of it. But sometimes in old age people or patients with susceptible population, for example, they have depression or they have a very unstable personality, what happens is basically is that these viral illnesses will have a prolonged recovery. We have seen this classically in normal people with COVID. So they have a post-COVID syndrome where the fatigue is predominant. Okay. So let us say you have a 2 days of viral illness and URTI, you will get relieved in 1 or 2 days. If that particular feeling of uneasiness prolongs over 2 to 3 days, then it is basically abnormal. So prolonged recovery is classical of infectious mononucleosis. It's mentioned in Harrison's also. So infectious mononucleosis and COVID are the most important causes mentioned in the textbook that can cause a prolonged recovery. So like I told you, it has to classify whether it is weakness or it is fatigability, dyspnea, or leg cramps. Somnolence. So somnolence is basically a easily elicitable symptom. You just have to ask him how fresh he is sleeping. Is he having any problems of sleep? any sleep disordered breathing, you ask the person who is next to him while sleeping, whether he's having snoring, whether he's having apneic episodes, etc. So this daytime somnolence is basically comes out as fatigue. Okay. So, but patients usually come and tell you that the patient is having, patient is actually sleepy. Okay. Sleepiness and fatigue can be confused, but more often than not, patient himself will come and tell you which is what. But the other symptoms, you have to be able to dissect and confirm. Okay. That is one important thing. So these are the things that in history that you need to ask. Next thing that is important is, like I told you, secondary causes need to be asked. Especially while examining also, you have to look for lymphadenopathy, organomegaly, any evidence of connective tissue disorder. Why connective tissue disorder is important for you to examine. So at the history level and at this examination level only, you are supposed to ask for connective tissue disorders or autoimmune phenotype. Only if this is present, you will go for ANA testing. Otherwise, ANA testing, routine ANA testing should not be done in a patient, even if the fatigue is extremely severe. Because even if the fatigue is extremely severe, there are a lot of patients who are having disorders other than connective tissue disorders. Connective tissue disorders don't present with fatigue as the most important symptom. Okay. So routine ANA testing is not done unless and until you find some kind of joint pain, rashes, problems with the nephrotic syndrome, urine proteinuria is present, all that. Only then you will do routine ANA testing. Some patients actually have these knots on their body, especially in the occiput, in the trapezius, in the thigh. You can feel like there is some kind of a knot that is present in the belly of the muscle. These are actually knots which could possibly indicate a possible fibromyalgia or a myofascial pain syndrome. And that can lead you to a diagnosis of these COPCs, which are chronic overlapping pain conditions. Okay. Breakaway weakness and fatigable weakness has to be tested. Now, I'm coming from history, I have finished. I'm coming to signs and symptoms. So how to elicit? So breakaway weakness and fatigable weakness, both are suggestive of, a breakaway weakness is suggestive of fatigue. So basically, when you say patient says, I'm not able to move this arm. Okay. But actually, when you test for power, he has a power of 5, not even 4 plus. That is because the power is, you are able to generate power. He just needed that instruction and then motivation to give that. So a well-motivated patient could generate a power of 5, even if they say the weakness is there in the arm. So these patients will be able to finish 80% of the movement. And at the last few degrees, they will suddenly give away. That is called as breakaway weakness. So breakaway weakness is characteristic of a functional disorder and fatigue also, but it is not not suggestive of a disorder of a neurological or orthopedic issue. Similarly, fatigable weakness. So basically, in myasthenia, we ask the patient to close and open his eyelid. Okay, or we can do a open arm test where basically he has to extend his arms and keep it for about 10 seconds. You have to see how he is able to sustain that movement. If he's unable to sustain that movement, prolonged contractions, possibly an MG disorder could be suspected. Next point is very important. Wherein you have a patient who's having a fatigue, okay, you don't have that much of pallor, but HB is normal. So usually what happens is they will neglect it and they'll send the patient back. But you have the patient, this is a classical patient, female who's coming from a village, let us say she has menorrhagia, etc. We don't. HB is normal. Okay. Does HB normal mean that the patient doesn't have iron deficiency? Or if the MCV is normal, does it mean that the patient doesn't have iron deficiency? No. Iron deficiency has 3 stages. First, the stores will go away, and then the MCV will change, and then the HB falls. So iron deficient erythropoiesis has to be detected, because iron deficiency erythropoiesis will have normal HB and normal MCV, but ferritin will be low. These patients you have to treat, because this could be a possible reason of fatigue. So much so that in heart failure patients, just the presence of decreased ferritin is enough to cause an acute exacerbation. You need not have HB to decrease. Just the ferritin being low is enough for the patient to exacerbate his symptoms. So you have to test for ferritin. So when you pass through all these stages, when you have to test, these are the important tests that you need to do: TSH, ESR, ferritin, potassium, vitamin D, calcium levels, urine protein, LFT and albumin, and CK. These are important things that you need to do baseline, okay, and no routine ANA testing. When you come to each symptom, like I told you, secondary causes are the treatable causes, and they occupy almost 90% of the cases. So you can never forget all these signs and symptoms on all these testing before you go ahead with anything. In a patient with the reproductive age group, UPT has to be done. Okay, there is no waiting or for signs and symptoms and all that. Please get consent and test for UPT. Neurologically, when you look at Harrison's, the causes of secondary cause of fatigue, he mentions MS as the first cause, and 90% of the patients of MS have fatigue. neurodegenerations, post-stroke central pain, all these have fatigue. Okay, you have to remember that. Sleep disorders, like I told you, will have fatigue solely because they're not rested well. In hypothyroidism, the weakness because of myopathy, where CK will be elevated, will accompany fatigue. So weakness with fatigue is a classical feature of hypothyroidism. Next point is adrenal insufficiency. Adrenal hormones are needed for basal metabolic rate, cortisol. When it is not there, you will definitely have fatigue. The next thing that is interesting is mild hypercalcemia. Mild hypercalcemia itself is enough to cause fatigue. Okay. But severe hypercalcemia will lead to lethargy. Please go back to your 21st edition Harrison's and see mild hypercalcemia is very difficult to suspect, and fatigue is definitely there in such patients also. But severe hypercalcemia presents with lethargy. Lethargy is basically a more severe form of fatigue where CNS symptoms predominate. They go into a state of stupor or some kind of grogginess will start appearing. Okay. Next, independent of glycemic levels, hyper or hyperglycemia will have fatigue. Independent of glycemic, you don't have to have a sugar of 400 or 40 to have fatigue. Fatigue is not the same as syncope. Okay, so fatigue is independent of glycemic levels in hypo or hyperglycemia, and low vitamin D levels especially has to be tested in such patients for coming with severe fatigue. CKD on MHD, CLD are important causes of fatigue as well. Now, when you come to infections, like I told you, infectious mononucleosis, SARS-CoV-1 and 2, and Ebola. These are the important causes of prolonged recovery post that illness has subsided. Okay, so that is important cause. So these are the important causes that I mentioned in Harrison's. And of these, please remember mild hypercalcemia. Please remember hypothyroidism because weakness will present with fatigue, and also remember infectious mononucleosis as a prolonged recovery illness. Okay, so once we finish this general management fatigue, I don't want to emphasize on this particular slide too much because everything is here. If you search the secondary cause, search, treat them. If you have not found a secondary cause, please get a second opinion. Please refer the patient to another physician and try to rule out a secondary cause. If secondary cause is not present, because then you are in a big dilemma because rest of it is basically supportive management. CBT and aerobic exercises. Okay, so CBT aerobic exercises are to be started first. They have a grade A recommendation. Strength of recommendation is very high. Okay, it occupies a very high level in treatment, not drugs. Okay, so once your patient is having a lot of sessions of CBT and aerobic exercises, you have to initiate resistance training. Without resistance training or without weight training, basically these patients will not probably improve. So resistant training or weight training is important for these patients. I told you previously also that depression is almost very closely related to fatigue because pure fatigue is a disorder of the mind also. Okay, it's a disorder of the psyche also. So in such patients, if you find that the depression symptoms are actually present, you can refer to a psychiatrist also. You can start the patient on antidepressants. It works on both fatigue and depression. But within 3 to 6 months, if the patient's depression is not coming down or the patient's fatigue is not coming down, you have to stop antidepressants. That's what Harrison tells, because antidepressant itself causes some amount of fatigue. Okay, so this is the general management of fatigue. So till now, what we have learned is about fatigue, how to, So till now, we have learned about how to analyze history of fatigue from this slide. Okay, this is very important slide. First, you have to see for all the secondary causes. And second, you have to go on putting closed-end questions of all these 1, 2, 3, 4, 5, 6. All these questions need to be asked to your patient. Reconfirm that it is only fatigue. And even if fatigue is present, sometimes the other part also is present. Okay, it can be fatigue with weakness, like in hypothyroidism, or fatigue with some kind of orthopedic issue also. So these kind of questions should be asked and confirmed if they're present or not. After that, you will definitely ask all these tests to be done. Okay, once you've got these tests and history, then almost 99.9% of the time, you have almost diagnosed the patient with some or the other disorder. Let us say if you don't find the disorder, where the secondary disorders are not clearly present, then you will probably call it as primary fatigue. Okay, so primary fatigue syndromes, basically, I have classified it for understanding as a symptom where fatigue is the predominant issue. Okay, where fatigue is what is the patient coming with. Okay, and all these tests have already been done. And another group of disorders where fatigue is not fatigue is just a part of a group of disorders, group of symptoms. So these symptoms, these group of disorders are called as COPCs, or chronic overlapping pain conditions. So chronic overlapping pain conditions are a group of disorders which are all having a high degree of co-occurrence. So co-occurrence, okay, this is important. It's present in Harrison's. This particular session, like other sessions, are not just based on one chapter. They're based on 3 or 4 chapters spread across the entire 2 volumes. So the COPCs actually come under neurology. So you can go back and see if you want under fibromyalgia. So COPC is basically a group of disorders with a high incidence of co-occurrence. And second, they have multifactorialism. The common thing is it's multifactorial. It's always multifactorial. There is some amount of problem in visceral and neurogenic. So there is an imbalance between the visceral neurogenic axis that cause, like brain-gut axis. Okay, so there's a problem in the brain-gut axis that leads to symptoms of a disorder. Okay, and all the tests always come out normal for these patients. Okay, so these are COPCs. So first thing is where fatigue is the prominent symptom. When fatigue is the predominant symptom, the first thing that we should learn about is chronic fatigue syndrome. So chronic fatigue syndrome is now being renamed as intolerance disease or systemic exercise intolerance disease, or SIDE. Okay, so chronic fatigue syndrome is also called as systemic exertion intolerance disease, exercise intolerance disease, because they're not able to tolerate the exercise. Okay, so now this was previously called as chronic fatigue syndrome or myalgic encephalomyelitis. Myalgic encephalomyelitis. If you go back to neurology and then find out if there's a chapter called as chronic fatigue syndrome, it has not been updated. So in that case, what happens is you need to keep yourself updated. So systemic exercise intolerance disorder, or SIDE, is now being called was previously called as myalgic encephalomyelitis or chronic fatigue syndrome. So this disorder, the first important symptom, look what is written. It is fatigue. Okay, fatigue is the first important thing, and that's the most important thing. So all your treatment strategies will be looking at fatigue, treatment of fatigue only, and not anything else. So then you have an unrefreshing sleep, you have cognitive impairment, you have PEM. I have told you again, what is PEM? Very classic. Everyone, it's not very easy to like just guess it. PEM is basically post-exertional malaise. So basically, what is malaise? So this question actually is sometimes very tricky. What is malaise? See, when you're having fever, let us say you put yourself into this story. When you have some kind of a disorder, like you're going to get URTI by the evening. Morning, you'll feel that uneasiness, something behind the throat itching. There's some few hours of you actually not feeling well. You know that you're not feeling normal. That is called as malaise. Malaise never stays for a very long period of time. Malaise always becomes severe, and you will end up having fever or sore throat. So malaise is literally lasts for few hours. Okay, so this is very typical. Okay, you have to experience to know it. So few hours of being uneasy or not normal is called as malaise, to understand it. Oh, generally, malaise is definitely pathological that eventually, becomes or increases to fever or sore throat or whatever symptom you have. But malaise should never last for more than few hours. If it lasts for more than few days, then it is abnormal. Then it is abnormal malaise. So that is called as post-exertional malaise. That malaise should never happen post-exercise. Okay, it is not fatigue. It is not post-exertional fatigue. It is post-exertional malaise. That is because the malaise that comes before your fever or sore throat is that uneasy feeling. It is not weakness, or it is not inability to do your activity. You'll be able to still do your activity, but you know that you are not normal and something is going to come in few hours. That malaise, if it comes after exertion and lasts for few days and not just hours, is called as PEM. So that is very important for you to know. So PEM is post-exertional malaise that is present in SIDE. You can have some kind of pain. You can have immune impairment. You can have orthostatic tolerance, which I've spoken in detail in one of the sessions. So, and then you can have susceptibility to infections. So these symptoms, with fatigue as the forerunner, is called as SIDE, or systemic exertional intolerance disease, now being called as, which was previously called as chronic fatigue syndrome or myalgic encephalomyelitis. Okay, so come to Harrison's definition is basically 6 months of all this. I've already told you, one, you should have a substantial reduction of activities of daily living because of fatigue. Fatigue should be profound. It is not mild self-limiting fatigue. Fatigue is extremely very severe. So that 6 months has to be there for 6 months. And after that, you should also have post-exertional malaise, which is not the same as fatigue. Then you will have unrefreshing sleep. You can have orthostatic intolerance or cognitive impairment. So this particular diagnosis is laid out by 2015 Institute of Medicine. So this is Institute of Medicine 2015 clinical case definition for chronic fatigue syndrome. Okay. So it has the axis, the brain gut axis or hypothalamic pituitary, whatever axis you want to put based on different organ systems. Central nervous system, autonomic nervous system is involved, and immune system is involved. So an interplay of all this with stress, genetics, diet, and infection as the triggers for occurrence of these particular symptoms. This is called as chronic fatigue syndrome. And the hallmark is that it's a persistent fatigue and the age group is 40 to 50 years. Please mind me, it is not young age. It is not 20-year-old female. 20-year-old female, you can possibly think of some other disorders like rheumatoid arthritis. You can think of autoimmune disorders, but this is basically 40 to 50-year-old women mostly that presents with chronic fatigue syndrome. Okay. And all secondary causes have been ruled out in such patients. Look at the interesting other important signs that are present in chronic fatigue syndrome is a tender lymph node. If you find a tender lymph node, you will definitely not think of something functional, or you won't think of something that is primary or idiopathic. But chronic fatigue syndrome will have tender lymph nodes. They'll have sore throat. Okay, they'll have temperature regulation dysfunction. So joint pain with swelling or without swelling or redness, muscle aches, new headaches, tender lymph nodes, sensitivity to sensory stimuli, alcohol intolerance, sore throat, difficulty with temperature regulations. These are all the additional symptoms that are present. So chronic fatigue syndrome in the same spectrum is associated with, I told you, all these. Okay, it's present directly in Harrison's. These are called as overlapping pain conditions or COPC, chronic overlapping pain conditions. What are they? Fibromyalgia, chronic migraine, temporomandibular joint disease, irritable bowel syndrome, endometriosis, vulvodynia, chronic pelvic pain, which is urologic chronic pelvic pain. All these are overlapping syndromes. The ones that are below are not under the overlapping syndromes, but have a high occurrence with chronic fatigue syndrome, which is POTS, allergies, Sjogren's syndrome, very important, Ehlers-Danlos, mast cell activation, dysautonomia, multiple chemical sensitivities. So these ones which are below are very specific for chronic fatigue syndromes, where the top one is basically COPCs, which we will be talking about. Overlapping syndromes. So Harrison's give you the small table on overlapping syndromes, and we are expected to understand the whole details of it. Overlapping syndromes, most important one is fibromyalgia. Others are also there. You can pick up either two things are there in overlapping syndromes. Either they're part of an organ system individually, like GI tract or GU tract or respiratory tract or whatever, or they can be not restrained to any particular organ system, but can be present in a particular region. Tricky to understand. Organ system means that the patient has some kind of problems with menorrhagia, or patient has diarrhea, constipation only. Okay, so they can be like IBS, or they can be dysmenorrhea. So these patients have this problem with the GI. This is the problem with the reproductive tract. So that is with respect to the organ system, and you have already found it also based on the symptoms and signs. This could be overlapping, a part of overlapping syndrome, or it could be present in a region. Is the pain in the region? So it could be called as chronic pelvic pain. So pelvic pain means the patient will just say, I have pain in the hip, pain inside the pelvis. They'll not be able to actually pinpoint where the pain is, but somewhere in the pelvis. But they need not have all symptoms of dysmenorrhea. They might not have IBS, or they might have everything, but they won't be having any conclusive particular organ system representation. That is regional. So overlapping syndromes can have organ system based or regional based or both. Okay, not restricted to any particular one. So these overlapping syndromes, I told you, have a high degree of co-occurrence. That means all the disorders under the overlapping syndrome will occur in the same patient with higher incidence. Okay. Now, the primary fatigue, the second part is when the fatigue is not the predominant symptom. So a lot of these symptoms with respect to each tract will take predominance, and fatigue will come as a part of it. Okay. So you might have dysmenorrhea with fatigue or IBS with fatigue. So that is called as overlapping syndrome. So this is chronic overlapping syndrome. Here we have already spoken about many disorders. Okay. We have spoken about chronic fatigue syndrome. We have spoken about chronic migraine in the previous session. We have spoken about chronic tension headache in the previous session. We are yet to speak about chronic low back pain. Today we'll be talking about interstitial cystitis. We'll be talking about fibromyalgia. So these and IBS later. So these disorders, other than vulvodynia, endometriosis, TMJ disorders, low back pain, all these disorders are having high degree of recurrence in the same patient. And that is called as chronic overlapping pain conditions. Okay. But what is not there in COPCs? You don't have causalgia. So chronic regional pain syndrome is only regional. That is why it is not there. So if it is only regional, then the patient is not like CRPS, basically. CRPS type 1 and type 2 is basically after trauma, sometimes without trauma. They might have certain degree of sympathetic dysfunction. They're called as causalgias. So they are not under COPCs. That is what you have to remember. Okay, they might ask this. That's why I'm telling CRPS is not in the spectrum of COPCs. So now we come to the two important diseases in COPCs, which is interstitial cystitis and fibromyalgia. These two I will be talking about in detail today, because the rest of the three disorders I've already spoken. So what is fibromyalgia? Fibromyalgia is a disorder where a female patient is having a lot of symptoms of basically pain. So it is widespread pain. Okay, it is not fatigue, but fatigue is occurring as a part of it. Widespread pain is definitely present. In these patients, you have to remember why I'm talking about fibromyalgia in a session of fatigue. It should have been spoken in a setting of pain. But why I'm speaking here is to emphasize the point that they have increased prevalence in patients with fatigue or fatigue-like syndromes. If in general population, you have fibromyalgia in 2% of the patients, in a patient who is having chronic fatigue syndrome or any of the other COPCs, fibromyalgia increases its incidence to 10 to 30%. That means in an already diagnosed rheumatoid arthritis patient, if the pain was initially only in the joints, now the pain has gone into the internal part of forearm or the shoulder or internal to the chest or the trapezius, etc. That rheumatoid arthritis pain should be restricted only here, but it is now going away from the site of pathology. So now you have to start suspecting if the patient has now developed triggered fibromyalgia. So basically, the secondary disorders or other autoimmune disorders trigger fibromyalgia. So fibromyalgia need not appear de novo also. It can appear after a particular disorder has been established. So typically, like I told, fibromyalgia has to be suspected if the pain radiates or if the pain is not explained or pain is out of proportion or if pain is gone away from the site of pathology in a particular disease. For example, in rheumatoid arthritis or in patients of ankylosing spondylitis. So fibromyalgia is basically a pain syndrome. Okay, it has a high degree of association with other fatigue syndromes. Now, this is what I have told you basically in Harrison's also. It is important for clinicians to be sensitive to pain management of these comorbid conditions so that when fibromyalgia emerges, characterized by pain outside the boundaries of what could reasonably be explained by the triggering condition. So outside the boundaries, if pain is coming, you have to suspect fibromyalgia and treat. And because fibromyalgia is a central pain syndrome, you have to give drugs that are not like NSAIDs. You can't give NSAIDs or local diclogel and expect the pain to come down. So you have to tackle the central pain pathways by giving other neuropathic drugs. That is the important thing. One important line is studies have indicated that some patients meeting the criteria for fibromyalgia have a small fiber neuropathy. Okay, it might be asked, that's why I'm telling you, small fiber neuropathy is typically present in some patients with fibromyalgia. Now, the old classification talks about tender points. Okay, but these tender points are also present in patients who are normal also. So we have removed away tender points. Just to say 11 out of 18 points should be present to call it fibromyalgia. These were the tender points: occiput, trapezius, supraspinatus, gluteal, greater trochanter, and so on. But these tender points are now gone away with the classification. The current 2016 ACR classification tells there should be a generalized pain in 4 out of 5 regions, and these 4 out of 5 regions should not include jaw, chest, and abdomen. Symptoms should have been present for at least 3 months. And usually there is a chart in which you have to assess the patient with respect to the amount of pain, the location of the pain, how much fatigue or how much sleep disturbance the patient is having. Based on that, you have widespread pain index and symptom severity score. These scores you have to calculate. If this WPI is more than 7 and SSS is more than 5, you can probably diagnose fibromyalgia. Okay, so basically it's not an exclusion of diagnosis. Here it's a catch feature why I'm telling this again and again, and why I've brought this under the fatigue session is because in fatigue, in other causes of fatigue also fibromyalgia can creep in. Usually when these kind of disorders come, we will exclude all other causes and then diagnose IBS. But in fibromyalgia, a diagnosis of fibromyalgia is valid irrespective. So fibromyalgia is not a diagnosis of exclusion. So that is what you have to remember. So these are the treatment agents that are specific to fibromyalgia. You cannot write whatever we feel like. You can't write nortriptyline and anything and everything. You have to use cyclobenzaprine, amitriptyline, which is the only FDA approved antidepressants, duloxetine, which is extremely efficacious because it has no side effects, but it is not having FDA approval. Milnacipran, these are both SNRIs. Pregabalin and gabapentin, which is acting on the calcium channel in the CNS, N-type calcium channel, and tramadol. So these are the only few drugs which are present in fibromyalgia. Please don't put any other drugs here. Okay. So currently, it should be emphasized, you cannot use strong opioid analgesics in fibromyalgia treatment. Okay. Now, it is advocated that you use a single agent to treat multiple disorders. So that's why history comes into importance here. So let us say if the patient has a pain and sleep disturbance together, then you're going to use a drug like cyclobenzaprine. So cyclobenzaprine is basically going to sedate and cause the fatigue to come down. Similarly, when the pain is associated with fatigue, anxiety or depression, you're going to use duloxetine or milnacipran, which has both antidepressant property and fatigue relieving property. So a single agent can be used from these to treat fibromyalgia. So fibromyalgia is a disorder of central pathway, but can be present in disorders of secondary disorder of fatigue. It can be present with primary disorder of fatigue also. So it can be present with rheumatoid arthritis, it can be present with chronic fatigue syndrome, or it can be present alone also. So it is not a diagnosis of exclusion. It has to have 3 months of symptoms for you to diagnose fibromyalgia. Here I have told you, look at the one that has level of evidence A and grade A and a strong recommendation. This permutation is present only in one particular treatment strategy, that is aerobic and strengthening exercise. Rest everything is lower recommendation. So that is all about fibromyalgia. The second thing that I want to talk about, and the last thing that I want to talk about in the fatigue chapter, is a primary fatigue syndrome where fatigue is not the primary disorder. Primary fatigue syndrome where fatigue is not the primary disorder, but the pain is the primary disorder. But patient will have fatigue. That is chronic pelvic pain. This is a regional pain where most of the patients are females. They can have dysmenorrhea, IBS, they could have interstitial cystitis, anything of that particular area in the anatomical pelvis. So basically, it's a non-cyclic pain. That is to rule out any particular endocrinological disorder. So a non-cyclic pain for 3 to 6 months or longer in the anatomical pelvis. Is called as chronic pelvic pain. Okay. And obviously, major disorders to be ruled out. So chronic pelvic pain is a symptom that can represent pathology in the specific organ system, like reproductive, urinary tract, or rectal, etc. A chronic pain syndrome or both. Chronic pain syndrome is basically a neurological disorder. So it could be a specific organ disorder or the problem with the pain sensitivity receptors and the nerves also, or both also. So that is called as chronic pain. So chronic pain does not include vulvodynia or vulval pain or perineal pain. Okay. This does not come under chronic pelvic pain. So if you look at the causes, lot of gynecological causes, anything and everything can come up over here. Urologic causes are important because we have to discuss few of them. So that is interstitial cystitis or painful bladder syndrome where it is idiopathic. This is primary. These are all having causes and particular treatment. Okay. So interstitial cystitis or painful bladder syndrome or BPS is what we're going to discuss. Then you have gastroenteritis, where the classical one is IBS. Everything else can also turn up. Musculoskeletal is trigger points in the pelvic floor. It could be pelvic floor tension myalgia, abdominal wall myofascial pain, fibromyalgia, coccygodynia, etc. Okay. So these are all the important causes for chronic pelvic pain. Then this is a disorder under chronic pelvic pain, which is called as UCPP or urological CPP, which is interstitial cystitis or bladder pain syndrome. This is a topic that was supposed to be done last session also under LUTS, because these patients present with lower urinary tract symptoms. Okay, so LUTS is present in these patients. Interstitial cystitis is a disorder of males and females, both alike. They are happening because of anti-proliferative factor or APF and loss of all the hyaluronans, GAGs, glucosaminoglycans. So the loss of GAGs on the bladder wall on the transitional epithelium and anti-proliferative factor leads to it's the probable hypothesis of interstitial cystitis. Classical thing that happens in these patients called as a Hunner's lesion, Hunner's ulcers. So these Hunner's ulcers will lead to a 6 months long pain, urinary tract pain. It could be cystitis, it could be strangury, it could be dysuria, urgency, frequency, any sorts of LUTS. So 6 months of these LUTS should be present. On cystoscopy, you can find a Hunner's ulcer sometimes. And these particular group of disorders, if no other cause is found out, we'll label it as IC or bladder pain syndrome. So in these bladder pain syndrome, you will do everything except for this. You will not do potassium sensitivity test, urodynamics, or bladder biopsy. So bladder biopsy is not indicated in any of these patients. That's very important for you to know. Otherwise, you will do urine cytology to rule out a cancer. You will give an intravesical anesthetic bladder challenge or hydrodistension. These two are optional. Okay. In patients who have tried everything else, young, tolerable, you can try these two. It's an anesthetic challenge with into the bladder intravesically. You can also give hydrodistension. Okay. Look at that. What they tell is you have to determine the clinical phenotype. Okay. So in clinical phenotype, you have to specify whether the patient has a Hunner's lesion or not. If the patient has Hunner's lesions, you can ablate the Hunner's lesions, or you can give a steroid injection. You can give a radical surgery or cyclosporin A. Okay, cyclosporin A, ablation or steroid injection of the Hunner's lesions. If it's a non-Hunner lesion, basically a mucosal erosion or just non-specific granulomas, you can give amitriptyline, cimetidine, intravesical therapy, hydrodistension, botulinum, and radical surgeries. Okay, so these are bladder or urethra-specific pains. So if Hunner lesions are present, there's a role for cyclosporin also. Okay, if there's a widespread systemic pain throughout the entire body, then you can give antidepressants. If there's a psychosocial, you can go for CBT. Associated infection, you give antimicrobials. Pelvic floor dysfunction, you give pelvic floor physiotherapy. Okay, where there's a trigger points are present on the pelvic floor. So you give trigger point injections also. That is pelvic floor dysfunction. Then you can have storage symptoms also. If storage symptoms are present from last class, you should remember that this is a problem of the sympathetic issue. Okay, so sympathetic issue will be present. So in that case, you can go for bladder training, intravesical therapy, hydrodistension, botulinum toxins, etc. Okay, so these are the symptoms that can present in a patient with interstitial cystitis. Okay. Typically, remember that Hunner's lesions, you can give cyclosporin A or Hunnerian steroid therapy. Okay. So that is what you have to remember. So this is a part of chronic pelvic pain under urological causes. Okay. So that's the only one that I've spoken about. Why I wanted to speak about these two only is because because of time constraint. Second is because we have finished a lot of it here. We have finished chronic fatigue syndrome, chronic migraine, tension type headache, fibromyalgia today, interstitial cystitis. We'll be talking about irritable bowel syndrome shortly and chronic low back pain also. Basically, all these disorders are having a high degree of co-occurrence. That's why they call us chronic overlapping pain conditions. Okay, so all these disorders will have fatigue as one of their symptoms, but is not the only symptom. Whereas if you look at this particular disorder, which is chronic fatigue syndrome or SIDE, this particular syndrome has fatigue as the most forthcoming symptom. Others are all basically very non-specific symptoms or constitutional symptoms. So chronic fatigue syndrome or myalgic encephalomyelitis is a forerunner primary fatigue disorder. Okay, others are not, but at the end we have to remember two important slides. One is this, which is dissecting fatigue and finding out whether fatigue is true and fatigue is isolated with only fatigue present, whether there's no weakness, there's no orthopedic issue, there's no pain, there's no leg cramps, air hunger, dyspnea, cardiorespiratory issue, anemia, etc. And after all these, all the talk about primary fatigue, please remember that secondary cause of fatigue is the ultimate and most predominant cause of fatigue. And you have to cross-check once or twice, get a second opinion before even attempting to approach a disorder of primary fatigue. Okay, so this is all about fatigue and COPCs. In next class, we'll be talking about dyspepsia and we'll start with GI symptoms. If there's any doubts, I'll take them now, or we can conclude the session.